Hello everyone, welcome back. If you're a physician working in the ICU, emergency department, internal medicine, or pulmonary medicine, respiratory acidosis is something you encounter frequently. Yet many clinicians struggle with interpreting compensation correctly and differentiating acute from chronic respiratory acidosis. In today's video, we'll discuss what respiratory acidosis is, common causes, physiological compensation, how to interpret ABGs correctly, clinical pitfalls, and a simple bedside approach. Let's begin. Respiratory acidosis occurs when alveolar ventilation decreases, causing carbon dioxide retention. Remember this equation. Partial pressure of arterial CO2 is inversely proportional to alveolar ventilation. When ventilation falls, CO2 accumulates, carbonic acid increases, hydrogen ion concentration rises, and blood pH falls. So respiratory acidosis is essentially hypercapnia causing acidemia. Diagnostic criteria. Arterial blood gas shows pH less than 7.35, CO2 greater than 45 millimeters of mercury. Whether bicarbonate is elevated depends on whether the process is acute or chronic. Think of causes in 4 major categories. Number 1. Central respiratory depression, mostly due to any one of the following reasons: opioid overdose, sedatives, brainstem stroke, and CNS infections. Number 2. Neuromuscular disorders like Guillain-Barré syndrome, myasthenia gravis, ALS, and cervical spinal cord injury. Number 3. Airway and lung diseases. For example, COPD exacerbation, severe asthma. Number 4. Chest wall or mechanical problems like morbid obesity, kyphoscoliosis, obesity hypoventilation syndrome, and mechanical ventilator underventilation. This distinction between acute and chronic process is extremely important. In acute respiratory acidosis, the kidneys haven't had enough time to compensate. Expected compensation. For every 10 millimeters of mercury increase in CO2 above 40, right arrow bicarbonate increases by about 1 milliequivalent per liter. Example: CO2 60 millimeters of mercury. Increase from baseline is 20 millimeters of mercury. So expected bicarbonate will be 24 plus 2 is equal to 26 milliequivalent per liter. If bicarbonate is much higher than expected, another metabolic process is present. In chronic respiratory acidosis, after approximately 3 to 5 days, kidneys retain bicarbonate. Expected compensation. For every 10 millimeters of mercury increase in CO2, right arrow bicarbonate increases by approximately 3.5 to 4 milliequivalent per liter. Example: CO2 60 millimeters of mercury. Expected bicarbonate will be 24 plus 8 is equal to 32 milliequivalent per liter. Typical example: a stable COPD patient. Let's look at these examples. Case 1. pH 7.22. CO2 60 millimeters of mercury. HCO3 26 milliequivalent per liter. Interpretation: acute respiratory acidosis. Compensation is appropriate. Likely opioid overdose or acute hypoventilation. Case 2. pH 7.36. CO2 60 millimeters of mercury, HCO3 33 milliequivalent per liter. Interpretation: chronic compensated respiratory acidosis. Typical stable COPD patient. Case 3. Pitch 7.10. CO2 60 millimeters of mercury, HCO3 20 milliequivalent per liter. Interpretation: respiratory acidosis plus metabolic acidosis. This is not appropriate compensation. Think of septic shock, lactic acidosis, renal failure, or diabetic ketoacidosis or other causes of metabolic acidosis in a patient with COPD. Whenever bicarbonate is lower than expected, always search for an additional metabolic acidosis. Respiratory acidosis is never caused by increased CO2 production alone. Hypercapnia requires inadequate alveolar ventilation. Do not normalize CO2 rapidly in COPD. Rapid correction may produce severe metabolic alkalosis and neurological complications. Always compare measured bicarbonate with expected compensation. If it doesn't match, there is likely a mixed acid-base disorder. Severe respiratory acidosis is a marker of ventilatory failure, not simply lung disease. Treat the underlying cause, not the blood gas. Management may include airway support, non-invasive ventilation, mechanical ventilation, bronchodilators, reversal of sedative medications, treatment of infection, and correction of neuromuscular weakness. Remember these 4 rules. High CO2 means respiratory acidosis. Acute compensation: plus 1 milliequivalent per liter bicarbonate for every 10 millimeters of mercury rise in CO2. Chronic compensation: plus 3.5 to 4 milliequivalent per liter bicarbonate for every 10 millimeters of mercury rise in CO2. If compensation doesn't fit, think of a mixed acid-base disorder. Mastering these simple rules makes ABG interpretation much easier in daily clinical practice. If you found this video helpful, please like, subscribe, and share it with your colleagues. Thank you for watching, and I'll see you in the next video.